Recording in progress.
Hello and good evening, everyone, and welcome to today's webinar in continuation with our trauma webinar series, which is an e-initiative of the Department of Pediatric Orthopedics in collaboration with the Uttar Pradesh Orthopedic Association. The module for today is Pediatric Wrist and Hand. I welcome all the reputed speakers who have taken time from their busy schedule for this webinar. I welcome all the attendees and delegates for this webinar. I request all the delegates to post their questions in the chat box, which will be answered at the end of the webinar. Or you can WhatsApp us on the number 9450758086. So without wasting any time, I request our organizing chairman, Professor Ajay Singh Sir, Head of Department, Pediatric Orthopedics, KGMU, to formally start the session and introduce the topic. Over to you, sir.
Thank you, Faisal. Once again, I welcome all my good friends who are here as a faculty. And this series we have started just to increase the sensitization and to press upon the importance of pediatric fracture and the fact that the management of pediatric fractures is different from that of adult fracture. With this theme, we have started this trauma series with the academic collaboration with the Uttar Pradesh Orthopedic Association. And we are very happy that today we are doing it for the wrist and hand. And I'm sure everybody will be benefited. I welcome again Dr. Faisal. Please carry on.
Thank you, sir, for the introduction for today's session and overall perspective of pediatric wrist and hand. I once again welcome all the delegates and remind them to post their questions in the chat box and also request to mute their mics so that the webinar is conducted smoothly. And we are also happy to share that this webinar is live on Zoom, YouTube, and Ortho TV for easy accessibility. We are looking forward for a great session ahead. We are really fortunate to have eminent and experienced faculty for this meeting. So without any further delay, I request our first speaker, Dr. K. Venkata Das, sir, who's the head of Pediatric Orthopedics Division of Department of Orthopedics at Ganga Hospital, Coimbatore. Sir has a specialized training in pediatric orthopedics and limb reconstruction. He has had his numerous fellowships and a fellowship at the Rady Children's Hospital in USA. And sir has also many international publications and authored many books. I welcome sir to present on the topic Pediatric Distal Radius Fracture, Evaluation and Management. Over to you, sir.
Thank you, Dr. Faisal, for the warm word of introduction. Good evening, everybody. And at the outset, I would like to thank the organizing team, Dr. Suresh Chand and Professor Ajay Singh for inviting me for this pediatric trauma webinar series. And today I'm going to talk on acute distal radius fractures. How do you go about evaluating and management of them? So I'm going to refrain myself from discussing delayed presentations and as well as complications of distal radius fractures. So distal radius fracture is undoubtedly one of the most common fracture in any pediatric trauma unit. And 80% of distal radius fractures are metaphyseal fractures. And if you see, about 40% of them will have associated ulnar fracture, like a both bone fracture. 40% of them have a single bone, isolated bone fracture. And 20% of them have physeal injury. So incidentally, distal radius physeal injury is one of the most common physeal injuries we encounter in pediatric orthopedic fracture. So how do we define a distal radius fracture? So sometimes it can be tricky to differentiate between distal 1/4 both bones fracture and a distal radius fracture. So I follow this definition which was given by AO. So you measure the width of the physis of distal radius and ulna and draw a square corresponding to the same measurement. And any fracture in this zone, we call it as distal radius fracture. So essentially, the distal radius fracture includes the fractures involving the epiphysis or physis of the distal radius and ulna, the metaphyseal fractures, and junctional fractures, that is exactly the junction between the epiphysis and metaphysis. And you can also have associated lesions of the ulna like ulnar physeal injuries, ulnar metaphyseal fractures, or ulnar styloid fractures. when you look at the classification, so in the entire lecture, I'm going to discuss about the distal radius metaphyseal fractures separately and physeal fractures separately. You can classify the metaphyseal fractures based on the direction as dorsal or volar fractures, and based on the fracture combinations, you can have either isolated radius fracture or radius with ulna associated fractures. So isolated ulnar fracture in this age group is a very rare injury. Biomechanical patterns, you can classify the fractures as torus fracture, either a green stick or complete fractures. And again, in complete fractures, you can have a length maintained or a bayonet opposition. So these are the fractures of various types of metaphyseal fractures. So this is a isolated radius fracture, a kind of torus fracture. Here you have radius and ulnar combination. Here you can see this ulnar styloid fracture, and here you can associated ulnar physis fracture. And this is the biomechanical patterns which I was talking about. This is a torus fracture, a green stick, which are incomplete fractures. And in complete fractures, you have a length maintained, both wounds fractures of the distal radius and ulna. And this is bayonet opposition, which is a classical bayonet opposition. So AO also has come out with the classification of pediatric fractures. And according to AO fractures, basically it is the same classification. They classify into incomplete fractures and complete fractures. And in complete fractures, you have either simple or multifragmentary fractures. So these are the basic classifications which are available. And coming on to the physeal injuries, Salter-Harris classification is the most widely used classification, even in distal radius. And I'm sure every one of you are aware of this. I'm not going to detail of this fracture. And these are just case examples of various types of Salter-Harris complete physeal separation type 1. And here the metaphyseal fragment type 2. And this is intra-articular fracture through and through the physis. It is type 4. And this is a type 5 fracture, which is a compression fracture, which usually presents later on with a physeal arrest or a growth arrest. With this, I'll move on to the clinical evaluation, which is more important. And a good clinical examination is definitely needed, even in a situation of acute trauma when the child is presenting with a pain. Pain could be a limiting factor to do a detailed examination, but one should persuade and do a detailed clinical examination. So one would think that what neurological injury can happen with a distal radius fracture. I'm going to show a case example in the following slides to emphasize the importance of a thorough neurological examination. It is not uncommon to see open wound in children, and what we have seen is usually the wound is on the volar side, and you should document the wound, look at the wound carefully, because missed wound can lead to an infection later on and disaster later on. And also you should remember to examine the joint above and below thoroughly. So this is a child who was a 14-year-old boy who had a fall, and he presented to the emergency like this. So this was a small wound on the medial side, which is a 2 into 1 centimeter wound. And on the clinical examination, we found that the little finger and ring finger, there was sluggish movements, and there was decreased sensation on the medial 2 fingers, which was suggestive of kind of ulnar nerve injury. So this was the X-ray of this patient. So if you look at the X-ray carefully, it looks like the radius has gone in medially here, and it has gone out in the anteromedial direction. So we know that this sharp spike of radius has gone out and again gone inside. And the ulnar fracture looks very innocuous, and we really do not know whether what is the cause of the ulnar nerve neuropraxia signs to the patient which he is having now. So this patient was taken up for debridement, and whenever we see a wound which is from inside and which is looking unhealthy, we tend to extend the wound and see the tip of the bone, make sure that there is no mud or muck inside. And luckily we found that the ulnar nerve was found in the fracture site on the ulnar fracture. So look at the fracture. It is such an innocuous looking fracture, but surprisingly the ulnar nerve was entrapped inside the fracture site here. And this nerve was found to be intact, and it was released from the fracture site, and the fracture was fixed in this fashion. So this is just a case example to show that neurological injuries can even happen in distal radius fracture. This need not happen in every other fracture. So 1 in 100 or 1 in 200 can have this fracture, but it is important that you examine every patient in the same way so that you don't miss that occasional patient with a neurological injury. Next is a radiological evaluation, and I cannot stress the importance of full-length X-ray. So it is important to take full-length X-rays, including the elbow, and we should always look at the elbow, the joint above and the joint below, and assess the fracture pattern and look for physeal involvement. And these days, WhatsApp consultation is not uncommon. This was sent to me by my friend who was practicing in a small town setup. So he has sent this 15-year-old boy I have here is casting enough. So whenever you are busy, you tend to give an opinion based on this X-ray, but never refrain from giving opinions based on one X-ray without seeing the proximal joint. And this patient had a proximal radial fracture. So when you see the elbow X-ray, the management completely changes. You have to take him inside for reduction of the radial head, and a 10 snail fixation of the radial head and pinning of the distal radius was done. So it is important to see the elbow joint in these fractures. Moving on to the management, I'm going to discuss the metaphyseal fractures separately initially, and then followed by the physeal fractures. So in the metaphyseal fractures, we have 4 different options of management. One is in situ casting, which is basically immobilizing the fracture in the same position which you get. The second is close reduction and casting. And the third option could be close reduction followed by pinning. And the fourth option is open reduction and plating. So how do you decide which option to choose for which patient? So there are certain parameters which you need to look at. And they are, first you look at the age of the child, then sex of the child, and then the fracture displacement and the fracture pattern. So we do know that the distal radius physis has a very high growth potential and a tremendous remodeling potential. So a lot of angulation can be compensated by the remodeling potential of distal radius fracture, and up to 100% of translation can remodel very well. Also a couple of case examples to show the remodeling potential of the distal radius. So this is a grossly displaced fracture of the distal radius in ulna in a child. And this is Dr. Sandeep Patwardhan's case. He did a close reduction, and after repositioning and casting, it was looking like this. But at 1 week, it started displacing, and at 2 weeks, if you see, the fracture is completely displaced. But he persisted with the cast, and this is 6 weeks after the fracture, and you can see that the fracture is healing well. You can see that the periosteum here is throwing out bone nicely, and this is 6 months of the after fracture. Very good remodeling, and 2 years follow-up. You can't even see where the fracture was. So this is the kind of remodeling which happens in pediatric distal radius fractures. This is yet another case to show the sagittal plane remodeling. So this is a 14-year-old boy who presented to us 6 weeks after his injury. Initially, he was treated with the oil bandage elsewhere. So we measured the angle of angulation, and it was about 26 degrees in this patient. And we decided to wait and watch, and over a period of 8 months, you can see. So this is the typical period of adolescent growth spurt. So within 8 months, the deformity of 26 degrees completely remodeled. So this is a acceptable limits of angulation, which is from Rockwood and Wilkins. As you can see, for various age groups, there are various angles which is described in sagittal plane and coronal plane. And if you take the lower level values for girls and higher level values for the boys, and this is general guidelines and it need not be followed strictly. As I showed, the previous patient was 14 years, and I personally tend to accept a little bit more of angulation than what is recommended here. I tend to accept up to 20 degrees of angulation in the sagittal plane. So we know that the sagittal plane remodeling is more because the joint, the axis of movement of the wrist joint is in the same plane, and we expect more remodeling. So I tend to accept up to 20 degrees of angulation, provided if the child is having a growth of 2 years left. So that's what I follow, and I tend to wait and watch rather than go jump and do an osteotomy in these children. The other thing which I do in clinical decision making is look at the clinical deformity. So if you have a 5-year or 4-year-old child with this fracture and this deformity, if you take an X-ray and say that the angle is 19 degrees, and if you want to treat it conservatively, and sometimes the parents may really be unhappy with this. Whereas on the other hand, if you look at this deformity, which is on the dorsal angulation, which is subtle, which can be managed by in situ casting, which is known to remodel well. So in my hands, the indication for reduction under anesthesia, or if the child is having an unacceptable clinical deformity, and if there is an angulation which is beyond the acceptable limits, both in the sagittal and the coronal plane. So now you now you know when to reduce the fracture. So what are the tips and tricks for how do you reduce the fracture? So simple fractures with uniplanar angulation like this, you just have to do the angulate in opposite direction, and I cannot stress the importance of a well-molded cast application, which is the most important factor in determining the success of your close reduction procedure. So you do a well-molded cast, and you measure the cast index, make that the cast index is less than 0.8. The most common cause of loss of reduction in this patient is actually a poorly applied cast. So if you apply the plaster very well, it goes on to heal in the desired position. There are certain fractures, particularly with the kind of bayonet apposition with angulation, when the periosteum on the dorsal aspect is intact, you may not be able to reduce by the usual maneuver. So in children, what we do is called the Pilcher maneuver or the hyperextension maneuver, where you have to exaggerate the deformity and then you reduce the fracture. So essentially in this, what you do is you exaggerate the deformity and then you walk down the fracture so that you get the reduction. So this is one such case example of a 12-year-old boy. So which we reduce. That's how you exaggerate the deformity, and with the thumb, I am just trying to walk this fracture over here, and gently with the thumb you flux the distal fragment to get the reduction. Once you get the reduction, then you apply this is the same patient whom we applied a good cast, which will go on to heal well. The other technique which is used commonly in distal radius fracture when you don't get a close reduction is intrafocal pinning, which is nothing but you place a K wire through the fracture site and then you lever the fragment, and then you can use the same wire and fix it like this. This is called the Capitate technique of intrafocal pinning, which can be of help in certain fractures when you are not able to get a close reduction. So this was published by the Cincinnati group in 2013 in the Journal of Paediatric Orthopedics. Let's see some of the common controversies which we come across in managing distal radius fractures. So what cast to apply, whether an above elbow or below elbow? This is one of the common dilemmas which we have. And second dilemma is when to pin, whether to pin or not to pin. So this is what I follow personally. Whenever I do a close reduction for distal radius fracture, just a close reduction without pinning, I try to play safe. I put an above elbow cast in supination for 3 weeks, and after 3 weeks, I convert them into below knee cast and start moving the elbow. So whenever we do pinning, close reduction along with pinning, I do a below elbow cast application. But the exceptions are when we have a junctional fracture, so which is at the exact junction of the metaphysis and the diaphysis, because these fractures are known for redisplacement, and we will not be able to get a good stable fixation with a pin. So I tend to put an above elbow cast in this situation. Also, if there is an associated fracture of the ulna, I tend to go for an above elbow cast. And if it's an associated distal radial ulnar joint subluxation, again I prefer to put above elbow cast in supination. So all my plasters for distal radius fractures are in supination, because we know that in pronation the brachioradialis will be tense and there is a chance for the posterior displacement of the distal fragment. So we prefer to put it in supination. The next dilemma is whether to pin or not. Again, there are umpteen number of studies in the literature. If you read the literature, you get really confused whether to pin or not. So there are literature to support casting alone as well as pinning, and both have their pros and cons. And I think one should make a decision on a case-to-case basis. So on my personal indications to do a pinning in a distal radius fracture is that when the fracture is unstable visibly after reduction, and if I'm able to pass an extraphysial pin placement. So whenever there is a need for a transphysial pin, so I try to avoid. So if you're able to get a good reduction and put a good cast, I think most of the time you will be able to get away with. So try and avoid placing transphysial pin unless it is a physial fracture. And again, metaphysial and diphysial junctional fractures, I tend to pin because these fractures are known for redisplacement. Let us look at some of the case examples. So this is a distal radius fracture with an associated slightly proximal fracture of the ulna. And so technically we can call it as a junctional fracture. This is how it was pinned. It's an extraphysial pin with a single pin. I just tend to put a single pin. You can also put one more pin from this direction, which is a cross pinning. And then we put an above elbow cast, which goes on to heal well in 6 weeks, and that's a 3 months follow-up. So this is a 12-year-old boy who had a fall at play. If you look at the fracture carefully, this is a good case for just an in situ casting, because you can see what this is called the bayonet apposition. The angulation is not much. So maybe hardly around less than 15 degrees of angulation. And this plane also, the angulation is less than 10 degrees. So this could have been easily managed with the ideal treatment. If I get the patient on day one like this, I would manage this with an in situ plaster and call him for a check X-ray after a week. So this patient was managed elsewhere. The surgeon decided to do close reduction and pinning, and this was how it was done. So you can see that he has passed 3 pins. One of the, looks like 2 of the pins are through the physis. This is the post-operative X-ray. The reduction looks pretty good. And at 6 weeks, as expected, the fracture healed on well and the wires was pulled out. But 2 years later, the boy was 14 years. He presented with a deformity, and you can see that there is a growth arrest of the distal radius, which is leading to this deformity. And 6 months later, the deformity was progressively increasing. And this is when the patient presented to us, and he is going to need a complex osteotomy to correct this deformity. So beware of transphysial pins. So is there a role for TENS nailing? So in pediatric practice now, TENS is supposed to be one of the most favorite implants, and I would say that it is one of the most abused implant as well. So this is a 9-year-old girl again, and the surgeon decided to do a TENS nailing for this fracture. So The reduction looks good. And at 6 weeks, the fracture healed well. And the only problem is this pin was placed transphysially and ulnar fracture also healed. And unfortunately, this girl developed a distal radial physial bar. And we did she presented to us with a physial bar. We did a bar excision and ulnar shortening osteotomy initially. And as expected, you know that the success of physial bar excision in distal radius is very poor. So it did not work, and she promptly came back with the persisting deformity and the ulnar impingement pain over the next 1.5 years. And then we had to go back and do a corrective lengthening osteotomy of the radius with further shortening of the ulnar to restore the ulnar variance and correct the deformity. And this is a final picture. So also these things also can happen when you do a TENS. And I want to show one more case which was done in our own unit. So if you are able to pass the TENS extraphysially, so can you do it? So this was a case which was done by one of our registrars. So he told that he'll try and pass the TENS for this fracture. So what happened? If you look at the definition for our distal radius fracture initially and draw the square, this comes under the category of junctional fracture. So exact junction between the metaphysis and the diaphysis. So intraoperatively, when he tried to pass the TENS, he splintered the distal radius completely. So once you splinter it, now your chance for pinning is also gone. So we had to do a just fixation for the radius and then do a TENS for ulna. And then it took a lot of time for this fracture to heal. We had to maintain them on just for quite about 3 months of duration. At 4 months, the fracture was looking like kind of healing. And this is at luckily at 1.5 years without any problem, the fracture healed well. So this is one of the lessons which we learned, that in the pure distal radius fracture, which is kind of junctional and metaphyseal and fractures, there is no role for a TENS nailing. What about plating? Is there a role for plating? It is rarely indicated because we do not have clear guidelines on this. So adolescents with volar Barton's type of fracture are one of the indications for plate fixation. So when you call adolescents, so this age cutoff when to do plating and when you can get away with pinning is really not clear in the literature. I'll show a couple of case examples. This is a 15-year-old girl who presented with this type of fracture, and this is a typical volarly displaced fracture which is known for redisplacement after pinning, and she was close to skeletal maturity, a girl at 15, and I thought that it is better to treat her as an adult, and we did a plating for her, which is a decent option in this particular patient. It went on to heal well. This is yet another patient, a 14-year-old boy. It's a similar looking fracture, so volarly displaced fracture, but for him we decided to go ahead and pin it. So this was how it was managed, with 2 KYs reduced and pinned and put a cast, and luckily it went on to heal well. So really
I request you to please wind up because time is running out.
Yeah, sure. So I'll go ahead to the how many minutes we have?
The time has gone. It was 15 minutes. We are 5 minutes ahead.
Okay. So I'll just physeal fractures. The principles of management are just the same for any physeal injury. And I'll close my presentation with this one atypical fracture which we came across some time back. This is a 14-year-old boy. If you look at the X-ray, initial X-ray, it looks very innocuous, which can pass away with like it doesn't look like a fracture. If you look carefully, the clear space between radius and ulna is obliterated, and there is small looking fracture. This was treated with the cast initially, and 2 weeks later it was called for follow-up. You can see that there is an increase in displacement, and the surgeon identified the displacement and took an MRI also. So it was managed elsewhere initially, and the MRI showed a Salter and Harris type 4 fracture, and the surgeon decided to treat it conservatively. Unfortunately, at 6 weeks, you can see that the child had a malunion with a carpal subluxation with restriction of movements and deformity. And this was how he presented to us, and we had to do an open reduction, transphyseal plating. And since you are crossing the physis, you have to do an ulnar epiphysiodesis as well, because otherwise you will get an ulnar impingement. So this is how he healed with full range of movements at 1 year follow-up without any functional disability. So this was a rare injury which we published in Journal of Hand Surgery in European volume. To summarize, so distal radius fracture is one of the common fracture in children, and you can have either metaphyseal, physeal, or junctional fractures. We need to differentiate between the three. And most of the fractures are amenable for conservative treatment. Close reduction and casting when the fracture is displaced beyond the limits of angulation. Pinning in very selected cases, and beware of junctional fractures. And in my experience, there is no indication for tensioning for pure distal radius fractures, and the need for open reduction and plates is extremely rare. Thank you for the kind attention.
Thank you so much, sir. It was indeed a very comprehensive presentation. Now we go to the next speaker.
Dr. Faisal, before you move forward, I would like to acknowledge the presence of Dr. Uda and Dr. Vikas Verma. And I welcome the Secretary of UPOA, Dr. Anup. Dr. Anup, welcome. Can you, if you if you can speak to a few lines, then we can move forward.
Thank you, Dr. Ajay Singh. I'm really happy to be here again for this. And it's a wonderful program which had been running under the UPOA by Department of Paediatric Orthopedics. And it's a great learning experience because this is a branch which is really has been propagated well. And Dr. Ajay Singh is one of the pioneer of starting the Pediatric Orthopedics department in KGMU, in fact, in the country. So I'm happy that this webinar had been continuing every month. So it's a pleasure to be here, and I'm thankful to the Dr. Ajay Singh and his whole team for conducting this webinar. And I'm really sorry for joining it late. That was because of my OPD concerns at this time, and it's a great learning process. Thank you, Dr. Ajay Singh, boss.
Thank you, Anup. Thank you. Please, Faisal, proceed, please.
Yes, sir. So now we go to the next speaker, Dr. Swagat Mahapatra, sir, who is the Associate Professor in Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Sir did his postdoctoral fellowship in hand and reconstructive surgery and deals in high volume of hand and microsurgery cases. He also has numerous publications in renowned journals in the field. I welcome sir to present on the topic, Diagnostic Approach to Pediatric Carpal Fractures. Over to you, sir.
Thank you so much, Dr. Faisal. Is my screen visible?
Screen is visible, sir.
Okay. So I'll be starting. So first of all, I would like to thank Professor Ajay Singh, sir, and his entire team of Pediatric Orthopedics for giving me this opportunity to speak on this topic. Now, coming to my presentation, it's diagnostic approach to pediatric carpal fractures. So the good thing about this presentation is actually it's very, very, very rare injury. What I was, when I was going through publications regarding this, I found that some popular pediatric orthopedic textbook called Rank's Textbook of Pediatric Orthopedics has only 10 lines dedicated to this carpal fractures in children. So I'll try to throw whatever light I can regarding this. So carpal fractures are relatively uncommon in children. However, during the past decade, there has been increasing recognition, mostly due to advent in imaging techniques. The carpus in the child is mainly cartilaginous and relatively immune to injury. However, considerable forces are required to injure the essentially unossified carpal bones. Thus, biomechanically, a fall on an outstretched hand is more likely to result in an injury to the distal radius and physis rather than to individual carpal bones. So as we heard before, Dr. Venkat, excellent presentation by him. The distal radius fractures are much, much more common than carpal fractures in pediatric age group. Most common carpal fracture is the scaphoid bone, even in adult as well as in the pediatric age group. Most common type of scaphoid fracture seen in pediatrics is the dorsoradial avulsion of the distal pole. Common carpal fracture is the capitate, but it is usually associated with a scaphoid fracture called a scaphocapitate syndrome. And all carpal fractures have a difficult diagnosis due to problem in interpretation of plain radiographs. So as per publications, as I have noted, 37% of carpal fractures in pediatrics are missed in the first X-ray. So we need to be very, very vigilant so that we don't miss this. So all carpal bones are surrounded by a growth plate and has an ossific center. So this growth plate offers protection and resistance to fracture. However, as the child grows, in adolescence, when a critical bone to cartilage ratio is reached, carpal bone fractures become more common. So carpal bone fractures is usually in an adolescent rather than a small child. And some specific things about carpals. Carpals lack a periosteal covering. Therefore, a periosteal reaction is not seen in imaging in healing of carpal fractures. Rather, sclerosis and bone resorption are more common radiographic findings in the late subacute stage. So this is a picture showing the ossification of carpal bones. We are all aware regarding this. We can just have a look and move forward. So now coming to a lateral view on a radiograph of a wrist. So the radius, the lunate and the capitate are aligned longitudinally in a straight line. And loss of this relationship is an important indicator of underlying carpal dislocation, as we see in the picture. Three smooth lines that can be drawn to outline the proximal and the distal row of the carpus. Again, disruption of these arcs signifies a carpal dislocation. There is another important sign called Terry-Thomas sign, which suggests a scapholunate ligament injury in adults. However, the space between the scaphoid and lunate should be less than 2 millimeter in a mature. However, greater than 2 millimeters, suggested could not be applied because dissociation cannot be diagnosed on X-ray in children. Or how to go about the imaging of a pediatric wrist fracture? Conventional X-rays first, done MRI if you are suspecting, if you cannot find a fracture, we are suspecting a bone bruise or a difficult fracture to find. In the wrist, and on eliciting signs, there is tenderness in the anatomical snuff box. The distal pole was historically the most common site of scaphoid fractures. However, in recent times, there is a change in pattern of scaphoid fractures more towards the adult pattern. This has been attributed to the increasing average body mass index of children and their increased participation in high impact athletic activities. So these are few X-rays. The first one on the left shows a dorsoradial avulsion of the scaphoid, which is the most common, as I had suggested. This one, the second one, shows a proximal pole fracture. These fractures have a high chance of non-union and avian. This is a waist fracture, which is progressing towards avian. However, in the last picture, we cannot find a fracture of the scaphoid, but there was pain in the anatomical snuff box. On imaging on MRI, this shows a bone bruise. So how do we go about managing scaphoid fractures? So dorsoradial avulsion, which is common, can be treated with a short arm thumb spica cast for 3 to 4 weeks. Waist fractures are usually treated with a long arm thumb spica cast for 6 weeks. And in case of established non-union of fractures, we go for a Mate-Rose procedure or a inlay bone graft technique along with fixation. Usually non-union of scaphoid in adults, these adults proceed for scaphoid non-union advanced collapse. However, almost no incidence of SNAC arthritis has been found in the pediatric age group. So this is the picture of a thumb spica cast. I just wanted to stress on the point that the application of thumb spica requires some expertise because the position of the thumb needs to be very perfect so that this functional range of motion is achieved once this cast is removed. So the pulp space of the thumb should be facing the pulp space of the index finger. This is the position in which a thumb spica cast should be applied. So these are 2 implants regularly used in the scaphoid in adults as well as in children who go for non-union or in displaced fractures. The one on the left is a Herbert screw. It works on the principle of differential compression. It's a smooth shaft and both sides are threaded, and these threads have differential pitch, due to which there is compression effect at the fracture site. The one on the right is a headless compression screw. This has uniform width throughout, but it has differential pitch all along. So personally, I prefer a headless compression screw, which I use in most of my cases of scaphoid fracture. So capitate fractures are the second most common carpal fracture seen. Isolated fractures are very minimally displaced and usually heal with conservative management in short arm cast. However, they are usually associated with scaphoid injuries called as scaphocapitate syndrome. This syndrome requires open reduction and fixation of both bones to avoid AVN of the scaphoid as well as the capitate. Now coming to the most important part of my presentation, which are lunate fractures and dislocations. Isolated lunate fractures are extremely rare. Most commonly, these presents as isolated lunate dislocation or transscaphoid perlunate dislocation. The treatment of these pediatric fractures is same as that of the adult pattern. So what we have to do is prompt reduction and fixation with wires and scaphoid screw fixation if indicated. Now I'll give a short overview of how to diagnose a carpal dislocation, usually a lunate dislocation. So what I have learned from my teachers, that the lunate standing here, so the middle friend is actually holding these two friends in control. The scaphoid, the left, this guy, the scaphoid, has a tendency to flex forwards, whereas the triquetrum has a tendency to shift backwards or extend. So when there is a tear of the lunotriquetral ligament, or there is a fracture of the triquetrum, the scaphoid easily pulls the lunate, easily pulls the volate to flex or volarly. Thus, the lunate will face volarly, causing a volar intercalated segmental instability. The same thing, once there is a tear of the lunate ligament or there is a fracture of the scaphoid, the triquetrum will pull the lunate and extend it. Thus, the lunate will face dorsally, causing a dorsal intercalated segmental instability. Moving on to my next slide. This is the way lunate dislocation proceeds. It's a Mayfield classification. So the first stage of a Mayfield classification, as we can see in this image, is there is a scapholunate injury causing a plain DISI, DC. So the second stage is dislocation of the capitate relative to the lunate. So if we come to the middle figure, first is the scapholunate ligament injury. Second is the dislocation of the capitate relative to the lunate. Third is a lunotriquetral ligament injury or a triquetrum fracture. And fourth is complete dislocation as seen here. So this is a spilled teacup sign on lateral view and a piece of pie sign on PA view. So it easily explains the process through which lunate dislocation proceeds, usually in 4 stages. Hope I am clear regarding this DC-VC and dislocation concept, because it took me, and I'm sure it takes a little time to understand this. So these are few examples, X-rays showing lunate dislocation and transscaphoid lunate dislocation. So treatment is same as for adult fractures, open reduction or closed reduction, fixation with wires for the dislocation, and in case of a scaphoid fracture, fixation with screw. Now coming to triquetrum fractures, extremely rare. However, they have a unique mechanism of injury. It usually occurs in hyperextension injuries where there is ulnar impingement of the triquetrum. The triquetrum gets crushed between the ulna and the rest of the carpal bones, and hence this is associated with chronic wrist pain even after healing. Usually treatable in a short cast for 4 weeks. These are few X-rays showing triquetrum, complete fracture of the triquetrum. Trapezium, trapezoid has treated conservatively, usually short-term cast for 3 to 4 weeks. So, to conclude,
Swagat sir, you are not audible. Hello. Yes. I think Swagat sir, you are not audible.
I got disconnected.
Yes.
So I've almost reached the end of my presentation. So I think I have already shared the trapezium, this slide.
Yes, sir, you already shared this.
So to conclude, injuries to the childhood carpus are very rare and unusual. The most important problem is establishment of a diagnosis of a fracture because there are difficulties in interpreting plain radiographs. And hence there are delays in diagnosis. Very few times displaced fractures may require open reduction and temporary immobilization. Thank you so much.
Thank you, sir.
I hope I finished in time.
Yes, sir. It was indeed a very good talk in a time frame.
Thank you.
So we are happy to share that we are being viewed live on Zoom, YouTube, and Ortho TV with together of around 125 people attending this webinar. I once again remind the viewers to post their questions in the chat box, which will be taken at the end of the webinar. Now I welcome our third speaker, Dr. Ajit Tiwari, sir, who's working as a consultant in Regency Hospital, Kanpur. He specializes in hand and microvascular reconstructive surgery and has 5 years of extensive training from various prestigious institutes and also possesses numerous publications in the field. I welcome sir to present his talk on pediatric phalangeal fractures, types, evaluation, and management. Over to you, sir.
My screen is visible?
Yes, sir, your screen is visible.
Thank you. Thank you, Faisal. I am very obliged to Professor Ajay Singh, sir, Pediatric Orthopedics Department of KGMU and UP Orthopedic Association for giving me this opportunity to talk on this pediatric phalangeal fractures. I'm going to talk on the pediatric fractures, pediatric hand injuries. Most of the fractures as treated by the conservative treatments, but I will highlight those fractures which requires kind of some interventions. So I don't have any disclosure regarding this talk. So how the pediatric fractures differs with the adults? They are the children's bone or the pediatric bones. They are the more flexible, so the more chances of bending and buccal fractures. They have a stronger periosteum compared to the adults, so they have stable reductions. That is why the most of the fracture can be treated conservatively. But these stronger periosteum sometimes create problem in the form of the they prevent reduction, because once they interpose at the fracture site, then it will become difficult to reduce the fracture accurately. And then in that conditions, you have to open and take out the soft tissue interpositions. It's faster healing as the pediatrics, as the child has enormous potential of the healing of the fractures. So the shorter cast-on time. The fractures unite faster, so the cast should be for the lesser time. But the flip side of this potential is that sometimes the patients come to us after some, that they presented to us delayed, and once the patient presented late, so it's difficult because the bone has united and it's difficult to correct. The longer cast, because it's difficult to immobilize the child, so you have to put the longer cast. The growth plate, as the growth plate is there, and there is always possibility, always chances of the growth plate arrest. But the good thing is that if the fracture is near to the growth plate, there's more chances of the remodeling. So once the physis is open, so that will causes once the fracture is closer to the physis, then there's a bone remodeling happens better, and the more remodeling happens. But this remodeling happens in the plane of flexion and extension. It is less predictable in the coronal plane, and the multiple reduction attempts of the physial fracture lead to the premature physial arrest. So if you see this, incidences of the fractures happens, or the injury happens in the kids. So the border digits or the border fingers are the more prone for these kind of injuries, especially the little fingers. And the mode of injuries basically depends on the mechanism of injury related to age. And most of the patients, they have the door trap injury. This is one of the most common kind of injuries where the patient has entrapment of the fingers in the door or the drawers or the almirahs. Somewhere the fingers got trapped there and the injuries happen to the fingers. There's, with due course of time and the ages passes, there's a patient have injury with the sports related and the play activities. So how do the clinical assessment when the patient has a fracture of the fingers and malrotation? So important thing is that all the fingers pointed towards this scaphoid, distal pole of the scaphoid or the scaphoid tuberosity. So all the fingers pointed towards the distal or scaphoid tuberosity. When there is a misalignment, or when the fingers is not pointing towards the scaphoid, it means there is a malrotation or the scissoring is there. So it's very difficult. Sometimes it is difficult to bend all the fingers to see the alignment. So in that scenario, you can bend the finger and see that this nail plate, bend the finger at the MCP joint around 90 degrees and see the nail plate. If the nail plate is rotated, it means that there's a rotation of the finger, there's a rotation at the fracture site happens. But as they are the small kids, they are not cooperative. Sometimes they don't obey our commands. So in that situation, you have to do something different maneuvers to know that there's a malrotation is there or not. Something is called tenodesis. When you will flex the fingers, when you'll flex the wrist, the finger will get extended. Once you extend the wrist, the finger will flex. This is called the tenodesis effect, and you can check the rotation of the fingers. Other maneuver is called the squeezing the muscles. Once you will squeeze the muscles in the forearm, all the flexors will get fingers will get flexed, and you can assess the rotation of the finger. So radiological examination is very important to know because there's a lot of that the black and white you can see in the fingers, because you should be very much aware that the epiphysis is fused or not, and where is the position of the epiphysis or where the position of the physis. So all the phalanges, they have the physis present at the base, and all the metacarpals, they have the physis at the head, except the first metacarpal, whereas the physis happens at the base of them. So other thing is that always do the PA oblique and lateral view of the hand. So you can see that the most important thing is that the many fractures miss due to the lack of the lateral view of the individual fingers. One view which is most important is the lateral view, and most of the places what happens that the people are doing the PA and oblique view and the lateral view is missed, and so many a time you can miss the injuries happens in the fingers or the fracture happens in the fingers because of the non-availability of the proper view of the X-ray. So in this talk, I would like to highlight, and I'll request everyone that who is listening my talk that please go for the lateral view of the individual finger to diagnose any fracture is there or not. Because if you'll not do the lateral view, you may miss many important things. So fingertip injury. So I'll start from the fingertip. The fingertip injury is basically presented the patients with the child presented with the subingual hematoma. Subingual hematoma is when there's injury happens to the nail bed. There's nail bed lacerations and blood is collected in between the nail bed and nail plate. So this is called the subingual hematoma. In fact, this is very painful conditions because there's a tight compartment and there's collection of the hematoma there, and the patient has a very severe pain. So it can be treated very well by the trephination. This technique is called trephination. You take a 16-number needle and get the patient anesthesia, distal finger anesthesia, and in full aseptic precautions, take 16 gauge needle, take out the hematoma, and patient will be very happy because the pain will go. And in adult case, you can take out the nail plate and remove repair the nail bed. But in pediatric cases, I will not recommend this, because once the nail plate is there, the nail bed will heal properly. Sometimes you can get that the fingertip injury or the thumb injuries where this patient has a fracture of the distal phalanx. This is called the Tuft fracture, as well as the nail bed injuries. So in that scenario, there is no need of the fixing this fracture, because they are the very small fractures. They are very small pieces. You cannot hold this. So once you do the proper nail bed repair with the fine sutures, so important thing, remember that the nail bed repair should be by the very small caliber sutures like 50 or 60, absorbable sutures like rapid vicryl or the catgut sutures, and after that you put the nail plate. So once you repair the nail bed properly, you don't need to put any kind of wire to fix the fractures, because this nail bed will support and the fracture will heal properly. So there are some problematic hand fractures. I would like to discuss these, because these problematic fractures, they account very small percentage of the fractures that are responsible for the large percentage of complications, though the incidences are less, but they contribute large percentage of complications. So what are these fractures? These are the phalangeal neck fractures, Seymour fractures, displaced articular fractures, and open fractures. Okay, so what is the principle of fixation of the hand fractures? So always remember that the small implant should be placed with the greater precision. And whatever the fixation we are doing, it should be the fascial friendly and simplest and the least invasive technique, because we should not put threaded K wires. We should not put multiple attempts to pass the wire through the epiphysis or through the physis, because this will injure the. So whatever the fixation we should do, it should be the fascial friendly fixation, and never open or the plate pediatrics hand fractures unless you have to do. These pediatric fractures, they are the they should be managed. They should be managed close. We should always try not to open these fractures, because if you open the fractures, the fragments are small and they have the very, that the vascularity is compromised, and you may land up in the kind of avascular necrosis of the fragments. So what are the indications of the surgical fractures? There's malrotations, deviations, unstable fractures, phalangeal neck fractures, Seymour fractures, unicondylar fractures, and displaced intra-articular fractures. Phalangeal neck fractures, one of the common injuries happen because of the entrapment of the fingers in the closing doors, and child try to extract the digit, and there's a fracture happens at the subchondral region. These fractures usually happen in the proximal phalanx and the middle phalanx. And so in this case, true lateral view is very important. So Al-Katan has given a classification of these kind of phalangeal fractures, phalangeal neck fractures. Type 1 is non-displaced fractures. Type 2 is when there is a displace with some bony contact is present, and type 3 is when there's displace with the no bony contact. So type 3 is further divided into various classification, various pattern. Basically depends on that how much rotation is there. If there's a 90-degree rotation, 180-degree rotation, and if the fragment is in the dorsally, flipped on the dorsally and down the volar side. So this classification is very useful for the treatment of the patient also. So the skeletal remodeling, skeletal remodeling in the phalangeal neck fractures is more likely in very young patients, occurs over many years during which persistent IP joint is limited, may be incomplete, will not be spontaneously correct rotational malalignment. So phalangeal neck fracture, this remodeling happens less. The reason behind this fracture is quite away from the fascial region. As I told you that the remodeling happens better when the fracture is closer to the physis, but these fractures are quite away, so the remodeling potential is very less. So the purpose of the treatment of these kind of fractures, there's near anatomical reduction to restore the subchondral recess. So these kind of fractures, the head should be properly reduced so that the subchondral recess should be attached. So what we follow, the similar kind of the paradigm we follow in the type 2 supracondylar fractures when the capitulum is quite behind in the type 2 fractures, and we have to correct the capitulum. So like the same pattern, we have to correct the neck fracture of the proximal phalanx so that the subchondral recess should be restored. So this Strauss has given a technique to reduce these kind of fractures. Very nice technique. how to do this, that bend the DIP joint so that the fracture will get reduced. If your fracture is not getting reduced by the bending the PIP joint, then you put a small 16 gauge needle. You can take 16 gauge needle or the small K-wires. Use it as a joystick or as a Kapanji technique, as Venkatesh has told. So we have to reduce the fracture. After reducing the fractures, once the fracture is reduced, pass a wire from the head to the base and head of the proximal phalanx. Take the wire out on the opposite side from the proximal phalanx head. And you can check again here is that the fracture is reduced or not. If fracture is not reduced properly, see the diagram D, and you can take out the wire a little bit proximally and you can reduce it again. And once
I request you to please wind up your presentation since we are running out of time.
Okay, but I got only 10 minutes. Okay, no worries. I'll finish fast. So there's sometimes after the fixing the proximal head of the middle phalanx, you can pass the wire again. So sometimes we receive the patient which has the incipient fractures, where I mean that the fracture patient is presenting late to us, and so in that scenario you can put the wire from the fracture site, put a wire and through the fracture site and reduce it and fix it. Seymour fracture is basically displaced phalangeal fractures of the distal phalanx. Important thing of the Seymour fracture is that there is entrapment of the nail bed germinal matrix over the fracture site. So we have to open this. This fracture should be open. Thorough debridement, nail plate removal, thorough debridement, take out the interposition of the germinal matrix, repair the germinal matrix, fix the fracture with the wires and the meticulous nail bed repair. So complications are the nail plate deformity, physical arrest. So there are some proximal phalangeal extraoctave fractures. So these extraoctave fractures happens at the base. So these fractures can be reduced by putting one pen or the pencil at the in between the fingers, and you can reduce it, and the deformity can be corrected. Intra-articular fractures, these fractures difficult to treat conservatively, but sometimes if it is reduced well, then it's okay. Otherwise, you have to open and put the K-wires or the screws. Then the metacarpal fractures, they should be treated as adult fractures. They happens in around the 15 year of days. And I want to summarize that the remodeling potential exists due to the open physis, occurs most in the line of the motion, basically the flexion extension, less in the coronal plane and not in the rotation. Increased risk of the physical arrest with multiple attempts at the fractures, manipulation, and the hard wire placement. Articular remains important in the pediatric fracture. Soft tissue alteration interposition may impede the fracture healing remodeling and avoid open reduction. Thank you. Thank you so much.
Thank you so much, sir. It was indeed a very brilliant talk. And so today we have completed 3 excellent lectures on pediatric wrist and hand. I'd like to open the question answer session. So to start with, there is a question for Dr. Venkat, sir.
Yeah, go ahead.
Yeah, so there's a question that does LaFontaine criteria hold good for pediatric age group? Asked by Dr.
Yeah, I replied to it. I don't think it is applicable to children. I personally don't think that it is applicable to children.
All right. So there's one more question that you said you apply plaster in supination, and which gives the explanation of brachioradialis pull, which is a culprit for dorsal angulation. So if that is so should it be required to apply the cast in mid-prone? What is your take on this?
Yeah, in mid-prone also it is relaxed. In supination also it is relaxed. So you can either apply in mid-prone or in supination. We apply in supination purely because we have found that over a period of years that if you immobilize in supination, pronation is a movement which is difficult to gain. It is easy, but if you immobilize in pronation, supination is a movement which is difficult to get back. And we don't have any problem. We have not seen any problem in immobilizing in supination, even for both bones, forearm fracture, whatever level, irrespective of middle third or proximal third. We always reduce the fracture and immobilize in supination. And this is something which is learned over the years. Because if we immobilize in pronation, we have seen that the patient takes long time to regain back the supination movement.
Right.
So that is the reason.
So there's a question for Swagat, sir. Sir, how do you approach a patient with physeal injury of the lower end radius, which is also associated with lunate fracture? The question is whether the lunate needs to be addressed at the same time, or what is your approach to this?
Usually, first of all, it's extremely rare too, because as we know, in children, the ligaments are much more stronger. So it's very rare. If it occurs, I think usually the lunate gets, because it's surrounded by bones from all sides, it usually is an undisplaced fracture. So what we have to do is we have to fix the distal radius or reduce the distal radius and treat the lunate conservatively. Only if it is highly displaced, we need to pass a wire from the distal radius through the lunate, fixing the lunate as well as the distal radius in one single wire.
Right. Right, sir. Thank you, sir. Sir, there's a question for Dr. Ajit, sir. That how do you approach a case? Sir, I request everyone to please mute their mics. Sir, Ajit, sir, am I audible?
Yeah, Faisal, please go ahead.
So there's a question that how do you approach a case with distal phalangeal physeal injury associated with nail bed injury? Does all case require open reduction, or and how does it varies from the treatment of mallet finger?
Yeah, so actually this whatever you asked, this is basically the same kind of fractures. When the patient has a lot of voices. So Anup sir, please unmute yourself.
Your mic.
Yeah. So, Faisal, there's a Seymour fractures when happen. There's basically there are two kind of fractures. There's one is what you say that the mallet fracture injuries, and there's the Seymour fracture. Seymour fracture is basically there's an epiphyseal injury happens. While the mallet fracture injuries, it's a proximal attachment happens at the extensor terminal tendon of the extensor. So in Seymour fracture, the important thing is that this is the open injury one. Most of the time it comes late, so there is always possibility of infection, chronic osteomyelitis, and these fractures you have to open because there is an interposition of the germinal matrix of the nail bed. So until unless you will not open, you cannot reduce it. So you have to open, you have to take out the nail bed from the fracture site, you have to reduce it. And sometimes it happens that once you repair the nail bed, it's stable. But sometimes it may possible that it's not stable even after repair of the nail bed. In that situation, you have to pass very small, fine wires through the physis, in the DIP joint, so that it will be stable. After 2 weeks or 3 weeks, you can take out the wires and it will be. As the mallet injury is there, mallet fracture is there, I think the conservative treatment is one of the best treatment. You put the mallet splint and it can be taken care of. But if very small child is there, which is not very cooperative, like 3 years, 4 years, I think you can pass a small wire and that will take care of things.
Right. So there's one more question, sir, for Ajit, sir. In extra-articular finger fractures in children, sir, how would you go for immobilization? Should we go for a buddy strapping or a splint immobilization, and what should be the duration?
Yeah, so if it is a fracture of the basically the phalanges, proximal phalanx or the medial phalanx, extra-articular fractures, let us see the rotation of the fingers. If the finger is not if there's no scissoring or the overlapping of the fingers, means there's no rotation, you just immobilize. Immobilization in the form of you can do the buddy strapping and you can put a small slab or a splint. I think splints works better because in between you can take out and you can start mobilizations. But if the child is not very cooperative, you can put the slab or you can put the cast also.
Right.
And, this is only for that thing. 2 week, 3 week is enough time.
Right. Thank you, sir. So there is one question for Swagat sir also. So in patients with phalangeal fractures, how often missed injuries have been encountered by you, especially in scaphoid fractures? And in the missed injuries, how do you approach it? So
usually what I have switched on. So what my experience I have seen is usually in metacarpal fractures, or in distal radius fractures. In both of this is associated with carpal injuries sometimes. So scaphoid fractures. So 99% of the time we either go for cast immobilization or fixation followed by immobilization. So by the time around 3 to 4 weeks, by the time the phalangeal, the metacarpal fracture heals, by the same time the scaphoid fracture also usually heals. Even if it doesn't heal, non-union is extremely rare. I think out of around 100 or 150, 120 cases I would have done, only one child I have done non-union scaphoid till now. 12-year-old boy, non-union scaphoid for 6 months. That's the only case I have done till today which required bone grafting. Otherwise, usually by the time the when other fractures heal, the scaphoid fracture also usually heals by that time.
Right.
Can I come?
Yeah, sure, sir.
So actually, these carpal injuries is a high energy injuries, and in the kids, high energy injuries are quite rare until unless this is open injury. If someone has open injury, then you may see that the kind of multiple carpal dislocations are these kind of injuries. Generally, closed injuries in the kids, they are not high energy injuries. These are the low energy injuries, and generally the carpal injuries are rare. But if it is closed injury, under cast, it will unite. And you know that if it is closed injuries, you may not see that there's gross displacement of the scaphoid fractures, or
exactly
carpal misalignment.
Right.
So I think we should know that the Venkat sir's opinion also about this. Venkat sir, can you come please?
Yeah, sorry, I missed the question. Can you just...
So the question is that how common is the carpal injuries in the kids, and how you'll manage the malunion or the non-union?
So unfortunately, because we have a separate hand injury unit who takes care of all the carpal injuries.
Yeah.
I don't treat carpal injuries. Whenever we see carpal injury, we send it to the hand injury unit, which is headed by Dr. Praveen Bharadwaj.
Yes.
I don't have any experience of even treating a scaphoid fracture. So we are all now diversified too much now.
Ajit,
yes,
Ajit, can I come in?
Yes, sir. Please, sir. Please.
Actually, we are not talking about only kids of 3, 4, 5 years. We are also talking about the adolescent and teenagers. We must look after any wrist injury if it is there. That X-ray for the benefit of my young friends and my students. If we are having any injury around the wrist joint, as old saying that one joint above, one joint below, then in any X-ray of the wrist joint, both rows of the carpal must be visualized, and we must learn to visualize these carpal bones and should not concentrate only on lower and radius. Carpal as such isolated are not so common, so there is a high tendency of missing these injuries.
Absolutely, sir. Absolutely. I agree with this, sir. I agree.
Thank you, sir. So there's one more question for Dr. Venkat, sir. So what approach you would advise if we require mini open for a delayed presentation of fracture distal and radius?
I prefer to go volar.
Okay.
Volar approach, yeah.
Okay. So there's one more question popping out for you.
Can I ask one question, Faisal, by the time?
Yeah, sure, sir.
So, Venkat sir, how do you manage a very distal fracture? I mean that when the fracture is very close to epiphysis and you know that it's quite displaced and you want to pin it, then what I found difficult that putting the wires in these kind of fractures, because you know that the holding both fragments, both proximal and distal fragment is quite distal, because the angulation doesn't come to hold the both proximal.
No, if there is a need to put a pin, and if the fracture is very distal, I do not hesitate to put a transphysial pin.
Okay.
Okay, so one shot, single attempt, smooth pin, which is like 1.6 to 1.8 millimeter, is not going to do harm. Multiple attempts is a problem. So if you get it in one shot, we have seen that it doesn't cause growth arrest.
How long you keep these wires, which is transphysial?
3 weeks.
Okay.
After 3 weeks, we remove it.
Okay, sir.
So the physial, Yeah, go ahead.
Sir, how does your approach change if the distal radius fracture is associated with ulnar styloid fracture?
If there is associated ulnar styloid fracture, see, the approach is almost the same because we always immobilize in supination, so it does not change much. We don't fix ulnar styloid fractures. It always falls back in place when you supinate and it heals well. We haven't seen the need for fixing an ulnar styloid fracture in a child so far. In adults, yes, I have done a couple of cases, but in children, no.
Venkat, one question from my side.
Yes,
sometime even after operating the Galeazzi fracture, the lower inferior radioulnar joint remain unstable. How you deal with that?
Sir, that's what I do. Previously I used to put pins, sir, but nowadays in supination it gets reduced. So we reduce it and immobilize in supination for 6 weeks in an above elbow plaster. So in spite of that, if it remains unstable after removal of the plaster, then we need to address it separately. But at the time of primary fixation, we prefer not to put any trans distal radioulnar joint wires from the radius to ulna or other ways, from the ulna to the radius. I don't think it's a good idea to do. But I've seen a couple of people doing it, but I personally don't feel comfortable by doing it.
Yes, I agree. Yeah, Faisal, please.
Thank you, sir. So I think with this, we come to the closure of the question and answer session. And with this, I would like to invite our very dynamic Dr. Suresh Chand, Assistant Professor in the Department of Pediatric Orthopedics, KGMU, to give the closing remarks and vote of thanks.
Thank you, Dr. Faisal. Good evening once again, everyone. And it is an honor to present summary of this excellent session, which was conducted by this webinar session on trauma. All the esteemed speakers presented superbly. And first speaker, Dr. Venkat, has presented on distal and radius fractures of pediatric age group. He has revised the classification of distal and radius fracture and including the AO classification. Also, he emphasized the importance of examination of neurovascular involvement in case of distal and radius fractures. Also, having a full length X-ray even in the wrist hand injuries. Also, he emphasized the remodeling potential of children, and mostly all of the distal radius fractures can be managed by closed reduction or a well-molded cast. Also, he cleared the technique of closed reduction, indications of pinning or not pinning it, and use of above elbow or below elbow cast, and what is the literature says and what is the approach at his institute, that is the Ganga Institute. The second speaker, Dr. Swagat sir, has spoken on the pediatric carpal fractures. And although carpal fractures are rare but not uncommon, and a high index of suspicion is warranted. And he very detailed way gave the explanation of Scaphoid Lunate triquetral relationship, and he very well explained the DCVC concept and the management of all the carpal fractures whenever they are there with the pediatric age group. The final talk was about the phalangeal fractures, and Dr. Ajit sir has very prominently highlighted the need of having a lateral view of phalanx fractures to avoid missing in a single AP or a oblique view. And he has highlighted how the pediatric phalangeal fractures differ from the adult fractures and how to assess the malrotation, and because the malrotation is difficult to remodel. And also he has described very well the evaluation and reduction technique of phalangeal neck fractures and other tips and tricks regarding this. So with this brief summary of excellent session today, I conclude with the vote of thanks. On behalf of organizing team and entire management team here, I extend my heartfelt gratitude to all the esteemed speakers for sparing their valuable time and sharing their knowledge and expertise in these highly less understood and less encountered fractures. And it has been a privilege to host all the members and audiences in this webinar. I am deeply thankful to all the speakers, Dr. Venkat sir, Dr. Swagat sir, and Dr. Ajit sir for their marvelous presentation. And with this, I thank Professor Ajay Singh sir for his constant guidance, teaching, and supervision for motivating and inspiring us at every point, and leading us in all these webinar sessions and otherwise also. I thank the team Pediatric Orthopedics KGMU, Dr. Najmul Huda sir, Dr. Vikas Verma sir, and my friend Dr. Faisal for a smooth organization of all the academic events, including this. I'm thankful to you, especially Dr. Anup Agarwal sir, Secretary UPA, for constant support in this trauma lecture series with Friday musings. I'm thankful to Johnson team, so Tirtho, Akansha, and all other members for their support with this Zoom platform. I'm thankful to Ortho TV team, Dr. Ashok Shamda and Dr. Noriyas Bijnali for their constant support. We are always thankful to our support staff from department as KGMU as well as the IT cell here for the constant support. And we always are thankful to all the participants for their active listening and attending. With this thanks note, I would like to request all the presentees to switch on their camera for a webinar selfie, and we'll conclude with this.
Thank the IT cell of KGMU who have supported us with the YouTube streaming.
Yeah.
Especially the Farhan. So thank you very much, everybody. It was an excellent session. Thank you very much. Good night, everyone.
Thank you.
Good night.
Thank you, everybody, and good night.
Good night.
Thank you.
Thank you so much, sir.
Hello.